The next part of our examination of the stomach takes us to the realm of gastric distension. And so we're going to start this off with basic, straightforward, give or take, gastric dilatation. And to derail this a little bit, the first question is, what is the right word to use? Is it dilation or dilatation? And the answer is, it probably doesn't matter too much. Strictly speaking, dilation is the action of dilating or stretching, whereas dilatation is a noun where it's the condition of being distended. So if you're talking about the name of the condition, it's really gastric dilatation. The reality is, unless you're writing a specific journal article, most people are just going to use the word dilation, and that's honestly fine. Just don't use the word dilated. The correct word is dilated. Dilated just sounds ridiculous. So we're talking about gastric dilatation, and physiologically or pathophysiologically, it can be caused by just about anything. Generally, it's some sort of decreased outflow, and one category of that is mechanical problems, so some sort of foreign body or mass, like a neoplasm, or pyloric hypertrophy, preventing flow of material, food, fluid from the stomach. It can also be a functional issue that's common with inflammation, whether that's gastric inflammation or the other yellow thing here, other inflammation, pancreatitis, enteritis, that results in kind of upstream reflex inhibition of the emptying. So the small intestine says, nope, I can't take anymore, and the nervous system slows down the stomach so less material gets to the small intestine in the first place. Every now and then it's due to too much inflow. So food bloat is a common condition here where basically overeating, the patient just eats too much and that's going to cause gastric distension. And if you give it enough time, it's going to empty itself out. But for a little bit, it's going to be a very distended stomach. When you see a distended stomach in a food bloat, you can't initially rule out an outflow problem, which is why serial radiographs become really important to follow that stomach over time, make sure that there is appropriate emptying. And then sometimes this gastric dilatation is incidental. A patient who's really painful or dyspneic may be very aerophagic and swallowing a lot of air, and that's going to secondarily cause distension of the stomach, but that's not really your primary problem. So this cat has a fairly distended stomach, but you can see it's all gas-filled, and in fact, there's actually gas moving into the small intestine and causing at least a little bit of distension of the small intestine. So there's no pyloric outflow obstruction here because the gas is moving all the way through. This is simply a dyspneic cat or an aerophagic cat for other reason who's swallowing a lot of air and distending the stomach for that reason, as well as moving on into the small intestine. Obviously, you'd want to correlate that with any GI signs that the patient may or may not have. So what do you see with a gastric dilatation? Obviously, you see distension of the stomach, and you have to decide how big is too big, and what is a normal degree of distension versus, again, too much dilatation. Again, there's lots of physiologic variation, so there's not a discrete cutoff as to okay versus too large. But one thing I always look at is look at the small intestine, and when there's a disparity in size between stomach and small intestine, so the stomach is dilated and the small intestine is empty, or at least not particularly dilated, that makes me more concerned that there's some sort of outflow problem. If the stomach is distended and there's a reasonable amount of stuff in the small intestine, then I'm more comfortable that material is getting through and it's less likely to be obstructed. Repeat radiographs are often a way to go to look and see if that distension is improving or worsening, and then you can decide if you want to do further studies. Again, you should remember, fast the patient. You don't want them eating more in the meantime because that's going to make it tougher to decide if the stomach is getting smaller or not. Ultimately, when it comes to gastric dilatation, the real question is this a more typical gastric dilatation, or is this a GDV? Is there a volvulus here? So with a straightforward, normal gastric dilatation, the pylorus and fundus are in the right spot. So the pylorus is on the right and ventral, the fundus is on the left and dorsal. So we'll go through some cases. Here's a dog, and I see a gigantic stomach with a lot of heterogeneous material, soft tissue and some gas opacity material throughout this humongous stomach. And that's severe gastric dilatation. And if I go to the VD view, I still see a giant stomach. And again, the question is ultimately, at least initially, is this a GDV or is everything in the right place? And I can see that this looks like a fundus. It's gigantic. It's on the correct side. It's a little bit smaller over here. That would fit with being the pylorus. So it looks like everything's in the right spot. All this material is kind of coarse and it looks at least plausible for food. So it's severe gastric dilatation, probably not foreign material, although I can't rule that out. But there's no evidence of GDV. Everything looks like it's in the right spot. So it's probably truly a food bloat and will improve with very conservative management. Here's another dog, again, a very giant stomach. This time mostly with gas. There's really not much food in there, so I don't think we're going to be talking about a food bloat on this one. There is a little bit of heterogeneous soft tissue stuff in the area of the pylorus, pyloric antrum sort of region. Again, big question, is this a GDV or gastric dilatation without volvulus? Well, the smallest area here should be the pylorus, because I know the pylorus is smaller than the fundus. It is ventral, and that's where it belongs, so it looks pretty good on this side of things. Also, I know that the pylorus lives on the right, and the non-gas stuff is in the pylorus, meaning it's also on the right side, which in this case, since it's a right lateral view, is the downside. So at least the material, the non-gas material, is acting gravity dependent, and so that kind of puts everything together as being that everything is in the right spot. So then we have to decide, why is this stomach actually dilated? The material could be foreign material, or it could be normal food. Maybe the stomach is distended because there's inflammation, or maybe that material is causing an obstruction. And so from the basis of what we've got here, we don't really know the final answer. In this case, we recheck the radiographs a few hours later, probably 6 hours later or so, and all of a sudden everything looks a lot better. So no more gastric distension. There's some fluid in the pylorus. Again, it's the right side down. Pylorus is on the right, so that's appropriate. Looks like our stomach is emptied out pretty nicely, so a lot less worry now. VD view, same case. Again, a non-distended stomach. So after some fasting, make sure there's no clinical signs of any excitement. We should be good to go and send this patient home. So on the flip side of this, what is a GDV? What does a gastric dilatation and volvulus look like? How do we differentiate that from the typical gastric dilatation without the volvulus? So in a GDV, the stomach twists, and usually it's about 180 degrees. So the pylorus goes from right to left. It goes from ventral to dorsal. The body and fundus do the opposite. So they're normally left and dorsal. Now they're going to flip, so they're right and ventral. Occasionally you'll get some oddity where the stomach twists 360 degrees, and those can be more difficult to confirm, at least from an imaging standpoint, although you'd still at least have a markedly distended stomach. But those are a little more challenging. Fortunately, those are pretty rare. Initially, the stomach will dilate with gas and then ultimately become more fluid-filled. When there's a GDV, a splenic torsion is possible because the spleen is attached to the stomach via the gastrosplenic ligament. So wherever the gastric fundus goes, so goes the spleen. Usually, the spleen at least gets congested in these cases because it is displaced. So again, this is something you want to look for radiographically. A lot of times we can't make a diagnosis of splenic torsion on radiographs, but it will be something to look for when you're in surgery. Likewise, gastric wall necrosis. A dog can have gas accumulating in the gastric wall when there's necrosis, and that can lead to rupture and pneumoperitoneum. Again, it's something we're going to want to look for on radiographs, but it may not be visible on radiographs, and it's something you'll have to assess in surgery. Other secondary changes, small intestine, there's a disturbance in the GI tract, so it tends to slow everything down. The small intestine is going to diffusely dilate, usually with gas. That's common just because, again, there's some sort of problem, and it's secondary. You don't really have to do anything with the small intestine, just get the stomach fixed, detours. Esophagus usually gets gas dilated as well. Again, that's secondary to the twisting of the stomach. If you get the stomach going the right way again, that will resolve. So again, no specific worries for the esophagus most of the time. So radiographically speaking, one thing we're going to see is dilatation of the stomach. Again, usually with gas, usually some amount of fluid, and it's usually quite severe, unless it's super acute, but even then it usually gets pretty severe pretty quickly. The only time it's less severe is when somebody has already decompressed it to some amount, either with trocherization or passing of a gastric tube. Pyloric displacement is a huge key. So again, the pylorus is supposed to live on the right and ventral, so if you see the pylorus on the left and dorsal, then you know that this is more than just a gastric dilatation, that it is really a GDV. And then kind of a bonus finding, a lot of people like it. It shows up most of the time, but not 100% of the time, is the compartmentalization sign. So people call it the double bubble or the Smurf hat or Popeye's arm, and I'll have some examples of that. Here are the key yellow things. I could put hashtags on these if you wanted. So dilatation of the stomach is going to be there. It's not specific, but it's an important first finding. That second bullet point is really the key sign. When you see the pylorus is in the wrong spot, that's your GDV. The third one is nice. If you see it as it is specific to GDV, it's not always present. In order to make the call, then, you have to be able to identify where the pylorus is. We see it best when it has gas in it. And so it's on the non-dependent side of the patient. So in a GDV, it's usually on the left, which is why we usually do a right lateral radiograph first in patients where we're concerned about GDV. So normally a right lateral radiograph, the pylorus is fluid-filled. So if I do a right lateral radiograph and I see a gas-filled pylorus, already I'm very, very, very concerned. So we got to do some cases. Here's a dog, it's got a GDV. I'm going to give a straightaway answer there. Spoiler alert. Very big gas-filled stomach. If I look at the more important findings, the big part of the stomach is ventral. So that's the fundus, and it's ventral. The smaller part is dorsal. I know the smaller part is pylorus. It's not supposed to be dorsal. That's a GDV. This is also a nice example of the compartmentalization, where there's this kind of appearance of a soft tissue wall separating the stomach into a couple of compartments. So that's Popeye's arm or the Smurf hat or whatever else you want to call it. So this has all the classic findings of a GDV. You can see it's a right lateral view, and my pylorus is in the wrong spot, and it has gas in it. So definitely on the left side as well as being dorsal. So there you go, GDV, pretty straightforward on that one. And for your notes, there you go, distended stomach, compartmentalization, there's the band, there's the pylorus. It's supposed to be where the yellow line is. There you go. We can do a left lateral view. Same story, it's a little harder to see because again, the big part is ventral. I know this is fundus and it's ventral, so even on the basis of this left lateral view, this is a GDV. It's just a little bit harder to call because I don't see a nice discrete pylorus up here, because that now left-sided pylorus is fluid-filled because we got a left lateral view and it's hard to see. So this is definitely a GDV. It's just a little bit harder to convince yourself because you can't find the pylorus. So right lateral view, again, is going to be your better bet for making that definitive diagnosis. Another case, another GDV, similar findings. For a lot of this, compartmentalization of this giant distended stomach. There's the pylorus, the smaller part. It's on the left side because this is a right lateral view and it's gassy. It's also dorsal and it's supposed to be ventral. So all of those things fit with GDV. As far as the secondary findings go, we do have a gas distended esophagus. Again, that's probably secondary to the GDV, and once we correct that, all will be well. And then there's one additional finding that is worth a mention, and that is this little band of gas that seems to follow along the edge of where the wall is. It's not really in the gas of the lumen, it's linear of the gastric wall. And so that is called gastric pneumatosis, and it indicates that there's gastric wall necrosis. And so that's something you're going to have to really deal with in surgery. Is that area of the stomach going to need to be resected? It could lead to perforation. So already prognosis-wise, we've kind of downgraded a little bit further. This is a bit more concerning even than the straightforward, quote-unquote, GDV. So that's it for gastric dilatation. Mostly we'll revisit it a little bit on some of our other disease processes in areas 3 and 4.